So Raymond Adili is an associate member and director of the Intravital Microscopy Imaging Core at BloodWorks Northwest Research Institute in Seattle. He received his medical education and residency training in cardiovascular surgery in China and research training in platelet biology and thrombosis at the University of Toronto. His research focuses on the mechanisms underlying thromboinflammation in different diseases using state-of-the-art intravital imaging and enhanced contrast molecular ultrasound imaging systems that otherwise couldn't be answered. I know we will be informed and entertained by Adili.
Thanks for kind introduction. Thanks for this opportunity. In vivo imaging is a very powerful technique to study biology in real time in animal models of disease. These are commonly used arterial thrombosis model in mice induced by different injury at different vessel, small and large, to see how platelet monitor how platelet adhere, aggregate, and form thrombosis at the site of vascular injury. These provide us with a lot of detailed information to understand how platelet respond to vascular injury, how they behave, how they react, and how they form a clot. And importantly, we're able to test all these key players. You all know all of these molecules, receptors, and that's how we improve our basic understanding of molecular basis of hemostasis. More importantly, we identify new target, test new drugs. Despite all these advantages of this arterial thrombosis model, they have certain limitations to study microvascular thrombosis, such as in thrombotic microangiopathy. Thrombotic microangiopathies are a group of disorders characterized by microangiopathic hemolytic anemia, severe thrombocytopenia, microvascular thrombi that lead to ischemia in key vital organs such as brain and the heart. And TTP is one of the most severe form of thrombotic microangiopathy, mainly associated with the deficiency of ADAMTS13 enzyme in plasma, a VWF cleaving enzyme. What happened is in a vasculature, when endothelial is activated, VWF release from activated endothelial exposed to the blood flow, which naturally attract platelet bind to VWF through VWF-A1 domain and GP1B on platelet surface. So interaction. And since we have a functional ADAMTS13 in plasma, ADAMTS13 quickly cleaves VWF, keep it in a non-thrombogenic smaller size so that keeps blood flowing. However, the situation would be very different when ADAMTS13 is deficient due to mutation or anti-ADAMTS13 antibody generation. In that event, when endothelial activate, there is no break to limit the platelet binding on VWF, so platelet continuously accumulate in a VWF self-associate, elongate, and only accelerate this process until completely clear all the circulating platelet and form systemic microvascular thrombosis. And we can study this disease process in ADAMTS13 deficient mice, despite they don't spontaneously develop TTP, just like a human. They need a secondary trigger. And what we did in this case is we transfuse large dose of recombinant VWF to the mice. As shown here, it results in quick platelet depletion, caused severe thrombocytopenia, and the mice got really sick. Also, there was red blood cell destruction, and some mice die as a result of this challenge. The obvious question we asked was, how does VWF clear platelets and cause thrombosis in vivo? In order to do this, we create a cranial window in mice as shown in the picture. By simply fluorescently labeled circulating platelets, we got very good visualization of microvasculature in brain. And this is what we observed when we transfuse large dose of VWF, recombinant VWF to the mice, ADAMTS13 deficient mice. And shortly after transfusion, we start seeing thrombosis in both venules and arterioles. The blood flow slow down, but as you noted, this is a very different thrombi than the ones that I just showed induced by injuries. These are mobile thrombi. They continuously form. In this case, in an artery, it's stuck at the bifurcation. And this is only after 20, 30 minutes of transfusion, and this process happens all over the microvasculature until all the circulating platelets are cleared. And this may also explain that why TTP patients have a transient neurological deficit, because these thrombi do not stay in some place, in this case stuck, but most of the time they continuously form emboli. And in close observation, what we noted is right after transfuse of recombinant VWF, we see platelets form this beads on the string kind of formation on a vessel wall, indicating that VWF is probably associated on the endothelial surface, provides this provides this network to capture the platelets, so that it's how it's onset the thrombotic process. Actually, we can confirm this with transfused recombinant fluorescently labeled VWF, and at least confirms that VWF is a driving force for thrombosis. Most surprisingly, what we found was the platelet adhesion and the thrombotic process in this disease model. So those platelets are resting, they don't express P-selectin on their surface. Most surprisingly, they don't express fibrin. And we can confirm this when we fire the laser cause injury. And this indicates that giving antiplatelet, anticoagulant treatment for TTP patient may not work very well, because platelet activation, the fibrin formation is not really involved in this process. But we have to target HDL, which is the main cause of, we have to target VWF, which is the main cause of the disease. If we give the recombinant ADAMTS13 prophylactically, we can completely prevent the disease process. Even after this complete occlusion of microvasculature, if we give the recombinant ADAMTS13, we can effectively restore blood flow in the brain and other organs, confirming that targeting VWF is the most effective treatment. And that's all about plasma VWF when it's extremely high. But in patients, the VWF is released from activated endothelial. So in order to study this, we set up this model. It's very simple. Mouse is transfused fluorescent platelets, and mesenteric vanule was exposed, and the platelets are fluorescently labeled. What we did was just topical drop of a calcium ionophore to activate the platelets. It resulted in a lot of platelet string formation, continuous emboli formation. This is in ADAMTS13 deficient mice. As expected, when we give the pre-treatment of recombinant ADAMTS13, we can completely prevent this thrombotic response, confirming the effect of targeting VWF treatment. And furthermore, in collaboration with Dr. Lopez, we studied what else would impact VWF self-association and the VWF-mediated thrombosis. And we showed that HDL is very good at protecting platelets from VWF-mediated clearance and the thrombosis. More importantly, a lot of patients live with a very high LDL, which is a bad cholesterol, and we tested this in wild-type mice, which has a normal level of ADAMTS13, and in a wild-type normal mice, we see only a single platelet transiently adhere and quickly clear. But if we give the pre-treatment of LDL to the wild-type mice, the situation is really bad, and we see continuous formation of VWF, continuous formation of platelet thrombosis, and this process don't resolve. In ADAMTS13 deficient mice, the process is resolved, but in the thrombotic phenotype in LDL treated mice with normal ADAMTS13 cannot resolve over the time, indicating that dyslipidemia is a really a risk factor for microangiopathy, and this may also imply that some TTP patients may not respond to the plasma exchange because it's not all about replacing the ADAMTS13 in TTP patients. There are other factors influence disease process, and there is a quantification. And in conclusion, what we're able to show is VWF is a key driving force in microvascular thrombosis, and targeting VWF, its VWF size, self-association is an effective treatment for preventing and resolving the thrombosis in TTP. And HDL, LDL can modulate VWF self-association and have a significant impact of VWF-mediated thrombosis. And I'd like to acknowledge my lab members and my collaborators, especially Dr. Lopez, who got me really interested into microvascular thrombosis. Thank you.
I'm just curious, you showed using the recombinant ADAMTS13. How long after a thrombosis has occurred can you use that? Sorry, go ahead.
Recombinant ADAMTS13, we tested prophylactic, which is 10 minutes before we challenge the mice with a high dose of recombinant VWF. We also tested 30 minutes after
30 minutes after.
Already start from microvascular.
Can you go longer after the thrombosis?
Yes, we do.
No, can you go beyond the 30 minutes? Can you go 60 minutes, 2 hours, 3 hours?
We observed up to 90 minutes.
Okay, and resolution?
Because of the limit, it still continuously works, yes.
Cool. Right. Okay, I think we'll move on. Thanks very much.
Thank you.